Host disabled, participant screen sharing.
I have enabled or disabled.
Has disabled.
Okay. I'm going to make you co-host
Okay.
and see if that helps. Hello, Rich.
Hello. Good afternoon, everyone.
Rich, we have captions. If you click on the CC at the bottom of your screen, you can turn on the captions.
Okay.
Drew, did you try to share your screen?
Yeah. I can share it.
Oh, good.
Okay.
Hey, Drew. Nice to see you again.
You see you, Rich. What a nice surprise.
Small world.
I know. I love it. All right. Zoom. All right. Let's get this going. Okay. So let's try this again. How's everybody doing? There we go.
Wow.
There we go.
All right.
Here or there.
Well, Marilyn, thank you so much for the nice introduction. It's an honor that you guys asked me to talk. And so I'm going to go through just some basics on tinnitus, on tinnitus retraining therapy, which is the treatment option that we do at Sound Relief. I'll tell you a little bit about the practice too, so you know, and then we'll open it up for questions. So can everyone hear me all right?
Yes.
All right, good. So as Marilyn said, I'm Dr. Drew Price, and which is funny about the news as of late, doctorate degrees come in all shapes and sizes, not just medical doctor, MD. I would call that more of a physician and not, you know, like I'm a doctor. Dr. Jill Biden is a doctor. My dad has a PhD in theology, so he's a doctor, right? So yeah, medical doctors are just one small sliver of doctors. So I'm a doctor of audiology. And so why an audiologist will specialize in tinnitus treatment is because the main underlying cause of tinnitus is hearing loss. There can be other connections, and this is something that Marilyn and I have discussed fairly recently, a couple of weeks ago. So I'll bring that up too, just because it has to do with the somatosensory system. So, okay. So what we're looking at is a picture of the auditory system, the peripheral auditory system. So what we do when we start with a tinnitus evaluation is we always want to look in the ear canal. So we look in the canal and make sure it's clear. If there's any wax or debris, we want to take it out. Then we want to know, is the middle ear system moving? So the eardrum, and I can't see my, oh wait, can you all see my mouse moving?
Yes.
Okay, good. So this is the eardrum. And then 1, 2, 3 little bones. That's called the ossicular chain. And sound gets a boost over this system when it goes to the inner ear. Still in the middle ear, if you're ever, you know, when you go up and down through the mountains or descending in an airplane and you want to pop your ears, that's this eustachian tube that opens and closes. Then we have the inner ear. So there's 5 balance organs in the inner ear, 3 spinning sensors and 2 gravity sensors. So when you go to an audiologist evaluation, they should ask about your balance. And then the snail-shaped organ is the cochlea, and that's the organ of hearing. So the inner ear is tiny, okay? All 6 organs are so small they could fit on your pinky nail. So when we think about hearing, overall health and wellness, right? Like adequate blood flow is really important to the health of those organs, just like the rest of the body. Other things that can cause hearing loss, family history of hearing loss, right? We can't fight genetics. just like some people are more genetically predisposed to sun damage, right? So some people can go in the sun and lay out for 4 hours and they get golden brown, whereas someone else will turn into a lobster after 15 minutes. Here, our hearing is the same way. So some people will be more susceptible to damage when in loud sounds than other people. Other things that cause hearing loss, certain diseases like diabetes gives you a 30% increased risk of hearing loss.
Really?
Cardiovascular disease gives you a 25% increased risk of hearing loss, right? If you have high or low blood pressure, that can cause more hearing loss. So we want to look at all those factors because a big question I get asked in tinnitus evaluations, which rightfully so, is why? Why do I have this, right? So we use the case history to help determine that. The really great thing about the body is there's no mysteries. There's always a reason that something's happening. You just have to ask enough questions to figure out what that reason is. So, like I said, these organs are so small they could fit on your pinky nail. So the next slide I'm going to show you is imaging from a cadaver lab. Okay. So on the left, we have what healthy hair cells in the cochlea and the organ of hearing look like. So these little rods, it almost looks like teeth on an imaging. Those are the little hair cells and this U-shaped structure that's called the stereocilia. So they move in fluid, right? So sound comes in over the middle ear, moves the hair cells in the fluid. There's nerve endings that connect to those hair cells and they send the sound up the brainstem into the brain. Okay. So any level of damage in the auditory system can cause tinnitus. Okay. And this is a really important point because I'd say, 95% of our patients that come to see sound relief are there for tinnitus as their main concern. And of the 95%, I'd say a good 80 to 85% would tell you, I hear just fine. It's just this tinnitus. But the brain doesn't care what our interpretation of normal versus not normal is, right? The brain's saying we're missing input, find it and fix it. I'm going to produce the sound I'm not getting. So we know that hair cells along that organ, they're like little piano keys. So if any of the keys are out of tune due to damage, right? Any of them, and the hearing portion of the cochlea is small, right? The cochlea hears from 20,000 hertz, so very, very, very high, all the way down to 20 hertz, very, very, very low, and everything in between. The speech frequencies are only 250 hertz to 8,000 hertz, right? So that's a very small range of what the human ear can hear. That's also often why patients will say, I communicate just fine. This sound is what's bothering me. It's why I'm here. So even in the presence of normal communication, even in the presence of a very, very, very mild hearing loss, tinnitus can still be present and it can still be bothersome. So what happens when there's, again, any damage to those hair cells? There's a lack of or change in information going from the organ to the brain. Okay, and the brain recognizes this. So the brain says, what's that sound? I want to heal myself, find it and fix it. So the brain starts creates hyperactivity. The auditory neurons overfire, and we perceive that as tinnitus. So tinnitus will sound like where you have hearing loss. Our goal with tinnitus retraining therapy is we want to rewire the brain to get you relief from tinnitus. So how do we know this? And where did all this research come from? So what we do at Sound Relief is called tinnitus retraining therapy, and it's been around for 30 years. It was started in 1988 by Dr. Powell Yastreboff. And so his research question, what started tinnitus retraining therapy was, okay, why do we have some patients who have very mild hearing loss, but they have severely bothersome tinnitus? Whereas we have other patients who have severe hearing loss, but mild or no tinnitus. Okay. So essentially, why does severity of tinnitus not correlate to the severity of hearing loss? And so the reason why is because the auditory system directly connects to the limbic system, which is the emotional brain. Okay. So the limbic system controls mood, personality, decision making. Okay. And how fast that pathway is, I'm going to give you another example. Have you ever, and I'm sure the answer is yes, everyone's done this, but when, you know, if you've ever been walking and you stumble, right, you trip and then you catch yourself, right? So you don't have to think about catching yourself. It's instinctive, right? That is the inner ear balance organs connecting to the cerebellum. Okay. And it's a direct pathway connection, right? So just as fast as the auditory system connects to the limbic system. Okay. So what happens when you trip, the balance organs send the message to the cerebellum. The cerebellum says, no, that's not right. Fix it. I know I'm making hand movements and you can't see them. But the cerebellum says, no, that's not right. Fix it. Sends the message back to the balance organs and you catch yourself. Okay. But that all happens in a split second. In that same way, the auditory system has an equally fast connection to the emotional brain. So the emotional brain makes decisions about sound before we get a conscious thought on it. Filter that, like the humming of the fridge. Amplify this, like a siren. Okay. So essentially, when tinnitus is bothersome, it's because the limbic system has said, amplify this. This sound is not safe. Find it and fix it. So I often describe tinnitus as a roller coaster ride that you did not sign up for. Some days it's loud, some days it's soft, some nights you can sleep, others you can't. Sometimes it's a ring, sometimes it's a static, sometimes a loud sound comes on and then it goes away. Okay. So the volatility of tinnitus is all coming from the limbic system. Okay. So the auditory system is just the main reason that it's there. The limbic system is why it changes. So what we're looking at is a graph of imaging. So all of tinnitus retraining therapy research is based on neural hyperactivity in the brain. Okay. So again, thinking back to the roller coaster of tinnitus, when your tinnitus is very, very bothersome, or if it's louder, if you're having trouble sleeping, then we would see your brain, where'd it go? Light up like this. Okay. That's it. That's it. Find it and fix it. I'm on high alert. You're not safe. I'm going to stay on high alert until you fix this. Okay. So why does it, what else can affect tinnitus? The big one, stress, right? I mean, and I say this respectfully because I'm young, but this is one of the craziest things that COVID, the pandemic is one of the craziest things that's happened in the last 60, 70 years. Now, I don't want to say 100 because we know what happened 100 years ago, the Spanish flu. But
Excuse me, Drew. Excuse me. We're getting some background noise and everyone is muted. Is it possible the noise is in your house?
Very possible. May I go look at it really quickly? I'll be right back.
Oh, okay. Okay. So while she's running to check on that noise, some people came in late. I want to make sure everyone knows we have captions. You just go down to CC at the bottom of your screen and select show subtitles. So I just want to make sure the latecomers know that. And we're gonna, that's why we should be muted. Phones ring. We're going to have questions at the end of her presentation. So please just keep your microphone muted. I muted some of you myself. I'm concerned you may not know how to unmute. So That would be in the lower left corner. When her presentation is finished and it's time for questions, everyone can unmute by clicking the microphone on the lower left side.
Is this better for me?
So far,
Okay. Yeah. Let me know if it comes back. Okay. So thinking back to getting back to the brain waves. So, stress can spike tinnitus. Fatigue can spike tinnitus. If you eat something you're allergic to, it can spike tinnitus. So that's something about the pandemic that's been very unique is what's changed in our lives. Increased stress, increased silence, and increased social isolation. That is the perfect storm for tinnitus to be more severe. And I've seen a lot of it. I've definitely had patients reporting more tinnitus disturbance than usual. So another analogy, I love analogies because it's complex. Tinnitus is invisible. Sound waves are invisible. So the closest phenomenon in the body to tinnitus is something called phantom limb syndrome. So if an amputee, when they lose a limb, sometimes they'll report pain or sensation in the missing limb. So why would that happen? Well, because the brain is reproducing the input that it's no longer getting. Okay. So that's essentially what the auditory system is doing. It's producing the sound that it's not getting from the cochlea to the brain, and then it's being graded by the limbic system. Why do patients have trouble sleeping? Well, tinnitus can be like a candle in a dark room. So a single flame in a dark room, can you guys hear me okay? Okay. A single flame in a dark room is not a very bright source of light, but whenever you add darkness, right, the darkness to light contrast makes the flame seem brighter. So on the other hand, if we turn on the lights, the flame is still lit. It's just not as bright. So this is our goal with tinnitus retraining therapy. It's one of them at least. So what we want to do with tinnitus retraining therapy is, of course, through the eval process, figure out, do you have hearing loss? Yes or no? And is there anything else affecting your tinnitus that's making it louder or softer, better or worse? So the goal with tinnitus retraining therapy, we use ear level sound therapy. So we want to turn the lights on, so to speak, with your tinnitus. So we want to add light contrast so that your tinnitus is not so bright, not so loud in silence, because silence always makes tinnitus seem louder or your awareness is drawn to it. This is another graph of just, what we've already talked about is what's, how does this happen? The main source of tinnitus is hearing loss. So the cochlea has missing input, sends that missed message to the brainstem. The brainstem produces the symptom of tinnitus so that the brain, the auditory cortex, the end of the pathway, knows what's missing and where. But then the limbic system gets involved because of that direct pathway connection. So the limbic system grades it. It says filter, right? I'm sure you've all talked to people who say, oh yeah, I've tinnitus. I've had it for years. It doesn't bother me, right? How? And you're like, it's taking over my life. How does it not bother you? Right? Or maybe you're somewhere in between where you have it. Sometimes it bothers you. Sometimes it doesn't, but it's not that big of a deal, right? You can be all across the spectrum. And why would you be? Just because of how your limbic system is grading tinnitus subconsciously. So when the limbic system says, okay, this is a problem, all hands on deck, it sends that message to the autonomic nervous system, which is breathing, heart rate, digestion. So when my patients tell me I can't sleep because of tinnitus, I'll lay down, I'm exhausted, and my body just keeps waking me up. That's the autonomic nervous system. It's telling you, don't fall asleep. You're not safe. So back to what we do about it. So the first step is we have to give the input back. Okay, we have to address the source. If the source of your tinnitus is hearing loss, which again, that's the main underlying cause, you have to start there. You have to treat your hearing loss. But 2, we have to calm the nervous system. Okay, we can't reduce the perception of tinnitus without first addressing the reaction from the central nervous system. Okay. And so that's really the bread and butter of tinnitus retraining therapy. It's the counseling part. Okay. The ear level sound therapy is important. Don't get me wrong. It's a vital piece of tinnitus retraining therapy, but the bigger part are the follow-up visits and the counseling. So my job as a clinician is to make my patients experts on tinnitus. I want my patients to get to a point where they don't need me anymore, right? They have the answers. And so what does that look like? What do you mean if they don't need you anymore? When my patients come in and they'll say, yeah, so a month ago I was having a spike, I was having trouble sleeping, but I knew it was work stress. And I realized that my diet had suffered from, I was eating more unhealthy foods because I was so stressed and I wasn't sleeping well. And then I wasn't working out because I was too tired. So I know that this cycle of poor health behaviors is what's causing my tinnitus to spike. As soon as I got back on track, it calmed back down. Right. And my patients will have not had, they didn't call me and work through this because we'd already armed them with the information. So they knew what to do. They're the expert on their bodies. They're the expert on their tinnitus triggers, and they got back to basics. So that's the goal. That's when I know I've done my job. So calming the nervous system, we have to give the input. We teach you about what's going on in your body we have something called the Tinnitus Retraining Therapy Guidebook. And that is what desensitizes the reaction. Okay. Once we desensitize your limbic system to the reaction of tinnitus, that's when your tinnitus softens and stabilizes. When I say tinnitus softens and stabilizes, we are actually rewiring the brain. We are teaching the brain that tinnitus is not a threat, so that even when the stressors of life come up, it doesn't mean your tinnitus is going to come up as well. And this I like to say everything and go through it and then review with the slides, just because it is pretty complex information. So again, main underlying cause of tinnitus is hearing loss. So this is representative of an audiogram. So right would be red, left would be blue. And we have across the bottom axis, we always have pitch. So how you would look at this is think about it as if you are sitting at the piano. So low pitches would be on the left, up to high pitches on the right. And then we have volume measured in decibels. So soft sounds would be up top, loud sounds would be towards the bottom. And what's significant about this line, we want everything as far as the volume that you can hear, the softest sound that you can hear pitch by pitch by pitch, we want it above that line. But again, remember, even if we have hearing thresholds right at the line or just a little below, that is enough for your brain to amplify tinnitus, and you can still have very bothersome tinnitus even in the presence of a mild hearing loss. Because although the auditory system mainly causes it, it's the limbic system that amplifies it. So step 2 is calming the nervous system. So again, we talked about ear level sound therapy. It's really important. It's a vital part of the process. The great thing about sound therapy is there's not one device, there's not one sound that works best. It is completely unique to the individual. So for example, there's a sound that I have my dad set up with It's called Zen. It's in a pair of Widex devices. I love Zen. I think it's very calming. I like Zen over nature sounds. Well, I like them both, but if I were to do tinnitus retraining therapy, I would start with Zen. Other patients, I'll put Zen on them and they'll say, do I have to listen to this all day long? That will tell me either the sound is too loud or they don't like it, right? Sometimes patients will say, gosh, this sounds like a clock or like church bells. This is distracting, right? So then immediately I know that's not the right sound therapy for them. So we want you to passively listen to the tinnitus program all day long. So when I say passive, I mean you should be able to carry on conversations. If you go into background noise, you don't hear the tones. I'll often ask my patients, all right, if you were sitting and reading a book in quiet or answering an important email, would you be able to focus on your task over the volume of the sound therapy? If the answer is no, or it's not a confident yes, that tells me the sound therapy is too loud. So passively listen to the program, soft input. All right, it's got to be calming. Why else is passive important? Well, you didn't pick this, right? No one picked to have tinnitus and no one picked for tinnitus to bother them. Your limbic system picked it. So because of that, we can't hide or mask tinnitus from the system that we're trying to reset. Okay, well, what happens if we mask it? It's going to spike your tinnitus. So as soon as you take the devices out, your tinnitus will come right up. So we don't want that to happen. We want to soften it over time. Okay, so it's important when we set sound therapy that you can still find your tinnitus if you go to look for it. So what makes tinnitus retraining therapy effective? Well, as far as the devices go, we want to wear them consistently. So all waking hours, as much as you can give your brain back that input, it's just going to treat your tinnitus more effectively and faster. Ear level. Sometimes patients will ask, well, can't I just, like you're giving me this sound, can't I just listen to a Bluetooth speaker all day or put headphones on? Unfortunately, no. Now, I do like my patients to use headphones or, a sound generator while they sleep, but it's not the same as ear level sound therapy because, again, what's the first step? We have to address the source of tinnitus, which is hearing loss, right? If I were to only give my patients ear level sound therapy without the hearing portion, they'd make a little bit of progress, but there'd be a plateau point. It's also customized, right? So yes, when I put an ocean wave in someone's ear or the Zen tones, it sounds similar to if you were to play an ocean wave from YouTube, but it's not because it's customized. It's customized and equalized to your prescriptive target, so to your hearing loss. So what would be my, how the software would equalize my tinnitus therapy would be different than my dad's, would be different from somebody else's patient, even with the same sound. It has to be dynamic. So the other great thing about tinnitus retraining therapy, it doesn't matter what sound you use. Any sound can work as long as you follow the same principles, right? So ocean waves are not better than running rain, rainfall are not better than pink noise, are not better than Zen tones. And this is well researched. There is no statistically significant difference in success as long as you follow the same principles of treat the missing input, treat the hearing loss, ear level sound therapy with the calming, soothing sound, and directive counseling. So the part where I make you an expert on tinnitus. Step 3. This we already talked about masking versus mixing. So on the far left, so again, we have pitch. So across the horizontal axis is, it's just a representative pitch, like you're sitting at the piano again. Low pitches on the left, up to high pitches on the right. But then we have low level sound. So if we're going from the bottom up the vertical graph where it says intensity, soft sound up to loud. Okay. So what you're looking at is, we know that when there's not much sound in our environment, when it's silent, tinnitus seems louder, right? Kind of like that candle in a really dark room. A teeny tiny source of light looks pretty bright when it's surrounded by darkness. Tinnitus, a relatively soft sound, seems louder when we're in silence or stressed, right? So we never want to give sound input so loud, right? Because soft up to loud. We never want sound input to be so loud that it masks the tinnitus. Because what's going to happen is, if we're masking this intensity, once we take the devices out, is just going to get louder. So instead, on the far right, we want to mix. So we want to make the tinnitus harder to find, right? We have to give you relief, right? If you have a sunburn, where's the worst place for you to be? In the sun, right? So we have to give you relief. We have to give you shade so that your brain can start the rewiring process. Okay. So it's important that you can still find your tinnitus if you go to look for it, but that it's harder to find, and then that with repeated exposure. Okay. So step 4 is rewiring the brain. So tinnitus retraining therapy is a 12 to 24 month process. Why so long? Well, you didn't pick this, right? You did not decide that you wanted to have tinnitus. Hold on one second. All right, y'all, just 1 second. I'm sorry about that. All right, the fun of pandemic presentations, huh? Okay, so we know that we are actually rewiring the brain. Okay, so sometimes patients will say, "So you're just going to put this sound on, and I'm going to ignore my tinnitus?" No. In the beginning, yes, right? We have to start somewhere. So the first 2 to 3 months, yeah, we are making you an expert on tinnitus, right? We give you, there's 7 lesson plans, our tinnitus retraining therapy guidebook. And so in those first 2 to 3 months, you are just trying to ignore the tinnitus, right? And again, I'm giving you skills to get there, but that is not what tinnitus retraining therapy does. Okay. We're actually rewiring the brain. So if we were to do a pre-treatment EEG recording, which we don't have to because it's been well researched for 32 years now, there's plenty of literature that show the more bothersome your tinnitus is, the more neural hyperactivity you have, and less efficient function, like our control group that does not have tinnitus. Okay. Oh, wait. Yeah. Hold on. I want to jump around. Okay. Here we go. This is, I was talking about this. Yeah. So, the first 12 months, it's 6 lessons, 6 follow-up visits minimum. So, as I was telling you, like what to expect with tinnitus retraining therapy, the first 2 to 3 months, that's when patients will say, okay, my tinnitus is more stable. It is more manageable when the devices are on. Okay. I still have bad days, I still have loud days, I still have soft days, but my loud days aren't quite as loud, and my soft days where I'm not as bothered by tinnitus, they're more frequent. Then by 6 to 8 months, that's when patients will say, hey, my tinnitus is softer when the devices are out. Okay, it's still not where I want to be, but I can see that it's getting better. So, but then we want to keep the habituation process moving. So you want to keep using the devices all waking hours through the 24 months, but then your visits, your visits get less and less. So, because again, you're the expert now, right? You don't need me to answer questions as much. Now, of course, I'm still there too, right? There's something that comes up, but again, my goal is to arm my patients with the information so that they know what's going on in their body. They have all the answers, and there's no surprises with tinnitus. So are you saying that I can stop after 24 months? It depends. So if you have significant hearing loss, right? So like my patients who have normal hearing or, borderline mild hearing loss, as long as it's stable, as long as through the 2 years and years after their hearing loss is stable and they don't have clinically significant hearing loss, they can stop wearing the devices, okay? Or use them as needed. But if you have clinically significant hearing loss, well, you can do whatever you want. You don't have to do anything, but my strong suggestion would be continue using the devices to treat your hearing loss. Okay. So, patients would say, but it's not my main concern. Tinnitus is. Yes, correct. But once we habituate your brain to tinnitus, we want to make sure that we are continuing to stimulate the auditory system. Okay. So why? The big reason, and this is one thing I wish I could shout from the rooftops as an audiologist, we know that smoking cigarettes causes cancer. We know that, you should brush your teeth twice a day and you should get 8 hours of sleep, exercise, eat your veggies. I want hearing loss when left untreated gives you an increased risk of early onset dementia. Like I want that taught right alongside all of our other health hygiene things. So we're working on that as a profession. But we know that hearing loss is perceived. So hearing is perceived in the temporal lobe of the brain. It's also a very important area for memory, speech, and of course hearing. So, because memory is is perceived in the temporal lobe, because hearing is perceived because memory is perceived in the temporal lobe, and hearing loss when left untreated can shrink that area of the brain. If you leave hearing loss untreated, it can affect your memory to the point that, and these are all different studies, all well researched, even a mild hearing loss, which quite honestly most people don't notice, but a mild hearing loss can give us a 200% increased risk of early onset dementia, and it just goes up from there. Of all the health risk factors of early onset dementia, mitigating hearing loss holds the greatest weight. So what is the best thing you can do to reduce your risk of memory loss? Treat your hearing over diet, over exercise, over vision loss, over treating depression. Hearing loss holds the greatest weight. So, and that is not this particular study, but if anybody's interested, I can send it to you. It's from the Lancet review. And the authors even said, we were surprised to find that hearing loss was the biggest health risk factor. So, okay. So a couple of the things, let's see. I like this one. So tinnitus retraining therapy, or TRT, is like learning to ride a bike or like learning a new skill. Like my new skill over the pandemic is bread making. I was not very good at it at first, but I'm getting better. I'm like learning to time my sourdough starter and learning how much I need to let it rise before I put it in the oven and getting my cast iron hot before I put it in, right? So just like with any new skill we're learning, tinnitus retraining therapy takes time, right? So there is no magic pill. It is not overnight. We are rewiring the brain, right? We are trying to form new neural pathways. And so that's why it takes 12 to 24 months. And that's why, it takes usually 6 to 8 months to really notice your tinnitus soften, even when the devices are out. Okay. One more thing I wanted to talk about, just because I have alluded to it, but it's not in the PowerPoint. So I'm going to stop sharing for a second and talk to you guys about it while I'm while I'm finding it. And this is something that Marilyn and I had a conversation about. I was telling her about something called somatic tinnitus. So somatic tinnitus means tinnitus coming from the somatosensory system. And 7. Let me get this pulled up. That is a research article. Okay, so we have 12 cranial nerves, and cranial nerve 8 is hearing imbalance. Of course, I have this beautiful graph at my office and I can't find it. Anatomy. Let's go innervation. Okay, so cranial nerve 8 is hearing imbalance. Cranial nerve 5. Will this one work? Cranial nerve 5, oh, here we go, is the trigeminal nerve, okay? So right on time, let me show you the trigeminal. Okay. It's loading. Okay. So the trigeminal nerve gets its name because it innervates the face like this, okay? So it's in orange. So if you look, you can see that it goes, up above into the skull, above the eyebrow, into the face, and then down what's called the mandible. So the maxilla is the top or top jaw, the mandible is the bottom jaw, and the trigeminal nerve controls a lot of function in the face. Okay. So when we have somatic tinnitus, it means it's coming from the somatosensory system. So I'd say that's the second most common, cause of tinnitus or something that can relate to it. So there's also the trigeminal nerve, and look, the trigeminal nerve also innervates the ear pretty close to the trigeminal. So if you have jaw tension, or if you have neck tension or pain, those can affect your tinnitus as well. It's pretty easy to figure. Let's say that not always easy. If it's jaw, it's pretty easy in the office. I can just say, clench down on your jaw, clench on your teeth. Does that change your tinnitus? Yes or no? Move your jaw forward and back, left and right, move your head or neck. So that's an easy way to quickly determine, is there a somatic component or not? It's not always that easy. Sometimes there's more in-depth questions we ask, but it's really just on a case-by-case basis. So one more thought about somatic tinnitus is, well, how do we know if it's somatic, if it's auditory, or if it's both? What if it's vascular, right? So typically, if it's going to be purely somatic tinnitus, then you should be able to find a head, neck, or jaw movement that completely extinguishes your tinnitus. Okay. So if you cannot find, a head, neck, or jaw movement that completely extinguishes it, there's probably another source, right? And again, the most common culprit, hearing loss. So, all right. Do y'all have any questions?
Okay, go ahead and unmute yourself if you have a question. And I can see everyone, so you can just raise your hand. Okay, Ken?
Yeah, my question is insurance. Is it dependent upon the carrier that you have, or do most insurance cover this?
That is a great question. Insurance, oh man, the more I know about insurance and work with insurance, the more convoluted it is. It depends on the plan. Okay. And this, I love that you asked me this, Ken, because this is my soapbox. I think every insurance company should give every person a $5,000 hearing benefit every 3 years. The research is there supporting it. So anyways, but that's not the case. So it depends on the plan. If you're ever curious, hey, is this covered by my plan? We can look it up. We at Sound Relief, we're not in network with a ton of insurance companies, but it's them. They're like, nope, we don't take any more providers in your area. So it's actually pretty hard to get in network with insurance companies. So, but an easy way to find out is we just take your plan, your group number, your member ID, your exact plan, and call and check. I have a list of questions I give my patients because I like, even when I get a great benefit, I like my patients to call and just double check, triple check. And then if it turns out that, hey, we're out of network, and of course this is Sound Relief specific, but if it turns out, hey, we're out of network, we will always, I'll look at an insurance discount that I extend to patients. We always want to take it after the claim processes, because if I'm giving you a discount, I want you to get it and not your insurance company. So, yeah.
Vicki?
Yes. Two questions. Do all audiologists have this tinnitus training to be able to help their patients, or is that somewhat specialized? And the second question is, we've heard tinnitus described as whooshing, ringing, banging, humming. What is it that makes the particular sound?
Great questions. So number one, so no, not all audiologists have specialized training in tinnitus. A lot of times it'll be on the website of, hey, we treat tinnitus, just to get you in the door. But, the common treatment is just, you have hearing loss, let's put hearing aids on you. That can work for some people. That is not, that's very, very different from tinnitus retraining therapy, which is, hey, we have to treat the tinnitus first. And to treat the tinnitus, we have to calm the limbic system and rewire the brain. So, putting hearing aids on you and saying, see you in 6 months, rarely helps. So that's the first thing. But everybody anybody can get trained in tinnitus retraining therapy, and it's fun. I love it. I get to know my patients really well. It's great. But number two, so why does the sound, what creates the sound? This is a great question. So most of the time it's coming from the auditory system, right? So wherever you're missing input can cause the sound to be present, okay? But rarely is there missing input at only one pitch, okay? So because it's usually a multitude of pitches, right? In music, we call that a harmonic, right? Many pitches played at the same time. That's why it can change so much. So how can it be a static and then it's a ring? Well, if it's a static, your brain is producing more of the pitches at the same time. It's more of a ring there, it's amplifying just, less pitches. So that's why it can change so much. The other reason it can change, right? So that's the auditory reason it can change. The other reason it can change so much is dependent upon the sensitivity in the limbic system, right? So if you have poor sleep the night before, your tinnitus might be louder. If you're more stressed about something, your tinnitus might be louder or change, right? Stress can make tinnitus more volatile, right? That roller coaster ride you didn't sign up for. So the goal is calm that.
Paula?
I have two questions too. I'm Paula. I would like to follow up on Ken's question. How much does it cost? Forget insurance and subsidies. How much how much does the training cost? And does it replace hearing aids for 24 months? Do they go to you instead of hearing aids?
That's a great question. So we have so some providers will have self-pay pricing and insurance pricing. We don't do that. We have one cost depending on level of technology. Okay. So, and it's gonna address the hearing question too. So at the very bottom of the barrel, like the cheapest entry level devices for tinnitus retraining therapy is $3,900 for the devices and all of your services, all the way up to $8,300 for the devices and for all of your services. Okay.
Depending on the technology. Okay.
Yes, exactly. Dependent upon the technology. So that little prepositional
And-
phrase for your next question. What's that?
Okay. Well,
Do you mean to answer the
okay, so that's not a hearing aid then. They don't get a hearing aid during that period, right?
They do. So that's the answer to your next question. I'm sorry, moving my screen. So it is still amplification, but it's plus some. Okay.
Oh.
So because so the hearing portion is important, right? Because it's the main underlying cause of tinnitus. So if I were to put a device on your ear and not treat your tinnitus, number one, it's unethical, right? I know that hearing loss gives an increased risk of early onset dementia. So I definitely want to address that, right? But beyond the memory loss aspect, it's the cause of tinnitus. Always want to go to the source. Okay. So the hearing portion is important, but the way that
okay.
with that.
Okay,
I'm sorry.
that's why I was wondering.
Yeah.
Does the device include a hearing aid?
Yes.
Okay. That.
Yeah. So it's hearing and sound therapy all in the same device. So it's called.
So that's what we're buying. Okay.
Yeah.
My other actual question was the most common injury reported by military veterans is tinnitus, and hearing loss is second. Do you treat a lot of military veterans? What proportion of your patients are in that, from combat noise or flight line noise?
Yeah, a lot. A percentage. Oh gosh. I'd say like probably 30% have some military experience. And it's you can also get services from the VA, but we do offer a military discount because vets are important. So yeah.
Okay, I just wondered that. Yeah, thanks.
Yeah, truck drivers. I have a lot of patients who drive trucks from the window being down. Hunters.
Many, yeah.
A lot of loud sound exposure. So good question.
Okay, Bernie has a question.
Bernie took more than half an hour to get connected.
Oh,
Oh my
I
God.
don't know how many times I had to say how many squares had traffic lights or motorcycles, and I just kept going through it and going through it. I went out completely and came back in a couple of times. It's very exciting to join. I'm glad I finally got in. But I was hoping to be able to talk to Dr. Price, because I can control my tinnitus partially. I have the hissing and the low hums go constantly. But if I put my head back, I get the crickets. And I can turn it off by putting my head forward, turn it on, going back, which is just amazing to me, because that means there's something physical connected to it. But it's very, very frustrating that I can't explain it, but I can control it just by putting my head back. There are the crickets stop, but all the rest is going all the time, and the crickets are just perceived in my right ear. Go figure.
somatic. your crickets in your right ear are somatic in nature. So, and you go by Bernie, right?
Yes. That's correct.
Bernie, we were just talking about that. Okay, you must have missed, but I was talking about somatic tinnitus and how, and you just described what I said. So great. Thank you. But if there's one component of your tinnitus, right? So what you just said is you have other sounds all the time, but you have crickets that when you go backwards, you can hear the crickets in your right ear. And when you go forward, you can make them go away, right? So
That's-
your crickets are coming from the somatosensory system and not from the ear, not from the auditory system. Right now, I am not a physical therapist, right? But I would say that for the cricket portion, that would be my next stop, would be to go see a physical therapist and look at some neck tension, neck and or jaw. So just to see, all right, can you give me exercises that make the crickets stop always?
Thank you.
You're welcome. Hey, and please, I think Marilyn's going to send my contact information out. If anybody has more questions or wants to talk to me in greater detail, I love questions and would be happy to talk to you about this. I love what I do, so happy to answer questions.
Okay, Ken.
Going along those lines, I have two questions also. The first is the cost per ear, or is that for both ears? Say
That's a
up
great
to
question.
300.
Yeah, that's for both ears and services.
That's
I
for-
should have
for
mentioned
both
that.
ears, not each ear. Okay.
Both ears, no,
Two-
2 ears and all of your services for the lifetime of the devices.
Okay. My second question is not really a question, but more of a statement. Would having input into the ears, say classical music, would that help with the dementia? Do you have any knowledge of? Go ahead.
I do have an answer. Yeah, that's a good question. So the answer is, it's, all right. The hard and fast answer is no. Okay. Would that help with dementia? Yes or no? I only get one, which would be hard for me. I'm wordy. If I get a yes or I get a no, it's a no. Okay. Because you need the specific input to the brain that in the pitches where you have hearing loss. Okay. So you can't confirm if you're only listening to classical music that classical music will be stimulating the correct hair cells all waking hours. So that's where amplification comes in. Is it stimulating the regions that you need all day? Now, classical music's lovely, so you could listen to it and it can help calm you. But as far as reducing your risk of dementia, we need the hearing portion. It's the only way. So
Okay, thank you.
Only way to treat the hearing risk of early onset dementia, right? There are other health risks that can increase your risk of early onset dementia, but hearing holds the biggest weight. I just wanted to clarify that. It's not the only thing that can cause dementia. Or I'm sorry, one more thing. We don't have causation yet. Like, I cannot tell you hearing loss, if you leave it untreated, it's going to cause dementia. Okay. That is being studied right now. But I misspoke and I wanted to clarify. We know that the two are correlated, a high correlation of all the health risks. Untreated hearing loss has the highest correlation to memory loss. So, thanks.
Janice, do you have a question?
I do. If somebody has 1 or 2 cochlear implants, can you do something to help with the tinnitus?
So
Because the
that-
ear, like I have one cochlear implant, that ear is deaf.
yeah, yeah.
And well, I don't hear the tinnitus when I have my cochlear implant in. I do have it in my other ear.
So wait, do you hear it in your other ear too when you take your implant off? That I'm sorry. May I
I'm
re-ask?
not sure. I'm not sure if I do.
Okay.
Um,
Yeah. Which is good. Don't start looking for it.
I know.
Sorry.
Like the sound is always there.
Yeah.
Most of the time, I seem to just be able to ignore it.
Yeah.
And I don't know how I did that, but I just learned how to do it myself.
You rewired your limbic system.
But like today,
Calm and
it's,
reaction with happens a perception.
yeah, I mean, there are times, and I think it's more
Do you
when
think
I'm
it's because
tired.
you knew we were going to talk about tinnitus today?
I'm sorry.
I said, do you think it's because you knew we were going to talk about tinnitus today?
Oh, like when you go to the dentist and your tooth hurts then and hasn't been hurting at all.
Yeah. Yeah.
No, I don't think so. Well, I know I didn't sleep very well last night.
Okay.
So
Okay.
I know that's part of it.
There you go.
But can you do anything for people?
Yeah,
with-
but see
Okay.
that thought process that you just did, like that's really the bulk of tinnitus retraining therapy is us me helping my okay, yeah, I feel like it's my internet. Can you guys can everybody still hear me?
Now we can
Am
hear
I- are
you,
we
but
good?
you have been
Okay,
breaking up with the video and the sound.
Okay.
But now we have.
Yeah, my internet has been a little rough lately. So, okay. So for implants, and this is something that I'm happy to look more in depth with you on, but, like, so if it's bothering you the most when you're sleeping, I would say you can get a sound generator pad, like it vibrates in response to sound. And I haven't looked them up in a while, but I could look them up with you. But you could get that for sleeping. But then because you still have, so to answer your question, I've never done tinnitus retraining therapy with binaural cochlear implants, but I have done it with patients who have one cochlear implant, one hearing aid. So,
I don't know if I need it,
yeah. if
but
it's
I was
not
curious with all this talk.
Yeah. 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 I mean, if it's not bothering you, could we get it to bother you any less? Right? Because that's the goal of tinnitus training therapy. So I agree with you, which is great. I love that.
Today it's bothering me, but I know I didn't sleep good last night. So
Right.
that's probably it.
So it's bothering you and you know exactly why. And you know what you need to do to help bring it back down. Better sleep, right?
We were all frozen for a minute there.
Thank you.
Okay, there are a few people I'd like to. Okay, we keep freezing, but Rich, can you hear me? Okay, Rich, can you unmute yourself and
I'm sorry, I didn't hear what you said after unmute myself.
okay, it keeps freezing. I don't know what's going on. Rich,
Yes. I can't. We might want to shut down our video to open up the voice part of the stream.
We didn't hear Dr. Price because she's on mute. When she was just talking, she's
Oh.
on mute. So that's what happened there.
Okay.
All right. Sorry about that, y'all. My internet's not great. So I'm just moving around. All right. So, what else? What other questions y'all have? No other questions? Can everybody still hear me?
Yes.
Okay.
And
All
I
right.
hear now.
I'm sorry.
I was trying to get Rich, where'd he go? He's over here now. I was trying to get Rich to introduce himself. Unmute yourself. There we go.
Okay. Yeah, my name is Rich Marr, and I'm the facilitator for the Denver Tinnitus Support Group. And we also hold Zoom meetings on the second Monday night of each month at 7 p.m. And we're gonna upload a new full version of Zoom so we can have longer meetings. So that'll be nice. But just one other note, we celebrated our 25th anniversary in October of this year, and we're still going strong. And you know, the COVID hasn't really slowed us down at all. We still have as many members come to meetings online as we did in person. So it's working out pretty well. I'd love to see people in person, but the thing is we're still connecting. We're still having conversations. And I'm even having people join in from California. Next month, we're going to have a fellow from Brazil join the group. So it's pretty cool. I got to say, it's pretty neat. And so we're always here. You can always go to our website, coloradotinnitus.org, if you want to find out about the group, where we're located, and get connected with me. So
May I add on to that? If y'all have not met Rich, he is one of my favorite people in the community. He is so passionate about what he does and all of the group members. So please do check out his group and talk to him. You're a really neat person, Rich.
thank you, Drew. I appreciate your
You're welcome. So good to see you.
And I just want to give a plug for Sound Relief. You know, they're the most dedicated team of tinnitus treatment people in the whole community here. They're all professionally trained. They're all silver or gold members of the ATA. So they stand behind what they're doing here. So I just wanted to let people know there's some top-notch professionals here in Denver that can help us.
Thank you so much. That's so kind. It's an honor. Appreciate it.
Okay. Bernie, oh, my light went out. Bernie, go ahead. You're muted, Bernie.
Now I'm not. How does your process or technology differ from Dr. Jenkins' sound technology, like pneumo something or other, neuro something, neuromonics, or just what is called a plain masker?
Yeah. So the unique thing about neuromonics, like the big difference is that neuromonics does not use amplification. Okay. So we know that we have to address the source of tinnitus, and the main underlying source of tinnitus is hearing loss. So neuromonics is something that, you know, if patients want to use it in addition to ear level sound therapy, you most certainly can. But it's not something that I like to fit by itself, because again, if I'm an audiologist and I know you have hearing loss and I know that's the underlying cause of your tinnitus, then I'd be doing you a disservice as your doctor by not stimulating your auditory system, right? Now, neuromonics is great. You know, there's a lot of research that goes into it. They pick those soundtracks in a very specific way. But again, you know, I'm going to get back on my insurance soapbox with Ken for a minute here. Unnecessary health costs are one of my biggest pet peeves, and I never want to be a provider contributing to the exorbitant expenses that our country has in healthcare. I mean, healthcare should be a right. It shouldn't be something that people lose their homes over. So just along those lines, you know, I basically never fit neuromonics because I would be asking you to spend a minimum of $10,000. And that just seems outrageous to me. And again, just because the system's 5,000. So if you have to get that on top of amplification, I mean, you're looking at a pretty high cost. So.
My other question was about maskers.
Did you already ask the question and I just forgot it? Do you mind reminding me?
My second question was, how does your technology compare to using maskers?
Oh, okay. Okay. So maskers are, so masking is volume specific. Okay. So you can take so I have patients who will use their sound therapy. I give them a volume control and they turn it into a masker. So it just means masking is just getting sound therapy up loud enough that it actually hides tinnitus from the brain. Okay, so I would say masking is based on volume. So how does it compare? Well, we don't want you to mask, right? So if somebody said, I'll always ask my patients, can you still find your tinnitus if you go to look for it? Yes or no? If the answer is no, then the volume of the sound therapy is too high and it is masking instead of mixing with the tinnitus. Good question.
I do have one more person I'd like to introduce. Virginia Ferraro. I didn't recognize her name and we can't see her, but that's Jenny. And she used to be in charge of the acoustic neuroma support group. So hold on. Can't see over the chat. Hold on. Yeah. So, Jenny, can you say hello to everybody?
Sure. Thank you, Marilyn. Hi, everybody. And Drew, we certainly appreciate this great presentation that you're doing. I think you spoke to our group probably over more than a year ago. And we really appreciate, all this information to help people make decisions about this, because yes, can be very costly, but something that we want to be able to address for sure.
Yeah, and yeah, as soon as I saw your name, I was like, oh my goodness, I know Jenny too. Yeah, I think it was even 2 years ago now.
Yeah. Yeah.
Time flies.
Yes,
so it's good to hear your voice.
Thank you. Yeah,
good. Is your group still meeting and when do they meet?
We are meeting on Zoom and it's about every 2 months that our groups, we don't meet monthly. But again, the wonderful thing about Zoom is that people can, no matter where they are, can join us. So I have people from California and Michigan and, they can just look up on the website when Zoom meetings are being offered all across the nation and whatever fits into their schedule. And that's the really good thing about Zoom right now, for sure. Yeah.
Okay, thank you, Jenny. Good to see you again.
Thank you, Marilyn.
She left, but Deanna was here, and I sent you all an email with her contact information. She's a patient of Dr. Price, and she's had really, really good success with controlling her tinnitus. So if you ever want to chat with someone about it, she was very eager to talk to anyone who was interested. Okay, I saw some hands. Ken.
I have one question for you, Marilyn. Can you resend out Dr. Drew's and Rich's information in an email to everybody?
Okay.
My second question is, we're spread out throughout Colorado from Grand Junction to Colorado Springs to Boulder and Denver. Do you do online, Dr. Drew, or do you have to come in person to for your services?
That is such a great question, Ken. I do a ton of telehealth. Even before the pandemic, I have patients who fly in from all over the country to come see us. Now it's something I was not doing before the pandemic, but I've done, I'd say like 5 patients now. I have like 5 patients who I've never met in person, and we've done everything remotely, and we're getting it done. So, you know, I preferably, like what's the most optimal way to start this is to have you come in person at least once for an evaluation, and then we can pick sound therapy. But if that's just not possible, I will work with you on it. I still remember I told my first patient, she was in Jersey. I was like, okay, so I've never worked with anyone who I haven't met in person, but we're gonna figure this out. And we did. And now it's like, now I have a system for patients who I've never met in person. So long-winded way to say, yes, we do telehealth.
Excellent.
I
Thank you.
have a question. Can you add your sound therapy to someone who already has hearing aids? Can it be added, or do you have to buy new hearing aids?
So the answer is yes. So it depends on the devices. So some like Costco, for example, Costco private labels their devices, and it's a totally different chip. So hearing manufacturers will use their old technology and will put it in Costco devices. So if you got your devices from Costco, I cannot adjust the programming. But yeah, if you have devices from an audiologist, we can use them for tinnitus retraining therapy. Yeah. Now, and let's say this, let's not give a blanket yes about anything. It's most devices we can use for tinnitus retraining therapy. So it's just something that if you bring them, I can look at them with you and say yes or no. So.
Yes, Vicki.
Does that mean that if you have several programs in your hearing device, that one program is for the therapy, or is it combined in all of your programs? That you in your hearing aid programs.
Yeah, that's a good question too. I'd say that's really on an individual basis. Like I have a patient who likes his tinnitus therapy on always. If he is streaming an audiobook, he wants a sound therapy on. If he is on a phone call, he wants a sound therapy on. If he's in his program 1, 2, 3, he wants a sound therapy on. So it's really an individualized basis. But for example, let's say you told me you have a comfort program that you like better than your normal startup program, and that's what you use the most, which thank you, modern technology. I can just check your data logging and see, if you use 2 programs in, the equal amount of time, then I would say, let's put the sound therapy in both of them, right? So the answer is we individualize it to you. So we can do it in one, we can do it in all. So good question.
Is it difficult to kind of, like, are you sort of hearing 2 different things, in a program that has both, the hearing and the therapy?
Yeah.
Is it like you're still like hearing through an additional noise that you've programmed in for the tinnitus therapy?
Yeah, that's a good question too. So the volume of the sound therapy is really important. So, if you were to get in your car and drive down the interstate, you shouldn't hear your sound therapy. If you're in the grocery store, at a restaurant, you shouldn't hear your sound therapy. You should just be hearing and communicating well. It still does its job. It's still rewiring the brain. It's just that you're not consciously aware of it. Okay. Now, when you get into quiet, it should be low enough that you can hear it and it's mixing with your tinnitus, but that it's not distracting you from tasks. It's a great question.
Great answer.
Thank you.
What about sleeping? You're not going to wear your hearing aids when you're sleeping. What do you suggest to do about tinnitus when you try to go to sleep?
Yeah. Another great question. So there is one device that you can sleep in. And it's funny when we were talking about cost, I was like, oh, I didn't mention Lyric. But so I'm glad you brought this up, Marilyn. So there is an extended wear device. It's Phonak Lyric. So it's a subscription-based model, and it's kind of like, you know, we have extended wear devices, only one Lyric. We have daily wear devices, which are the receiver in the canal, in the ear, etc. So Lyric, you sleep in, you shower in, you can't lose it because it's always in your ears. And every 6 to 8 weeks, we take it out, the device dies, we put a new device in. So those devices have a different pricing schedule or structure rather. Lyric is $3,600 for both ears annually. So it does, you know, if you think about wearing Lyric for 10 plus years, it can get a little pricey. But another way to think about it is, well, what if you have very bothersome tinnitus and we only use Lyric for 1 year to treat your tinnitus, and then we switch you to something else, you know, after 1 year or 2 years, okay? So just know that Lyric exists, and it's something that you can sleep in to treat tinnitus, okay? But the other, okay, well, what if I have receiver and the canal devices and I take them out to sleep, right? I don't want to spend $3,600 a year. I don't blame you. So what you do if you have daily wear devices is you can use bedside sound therapy. So you can use like a sound generator that you either set on your bed, you know, beside your bed on a nightstand. There are pillow speakers you can use. There's a headband version you can use, you know, because sometimes patients will say, well, my spouse wants the room silent, but as you know, silence is the worst thing for me. You know, so that's always something that I can work, you know, have the spouses come in and we can have a conversation about, you know, sometimes just hearing the why. You know, I want you to use, you know, can you use this? Are you open to trying it so that your husband can get better sleep or your wife can get better sleep? So that's always something I do too. Good questions.
Stan, do you have any questions? I muted you earlier and I'm worried you don't know how to unmute yourself.
I have, you know, I live in a condo and I don't have tinnitus. I don't think I do anyway. But about 3 months ago, I woke up about 12 o'clock at night and I thought it was a fire alarm. But I walked the halls and, you know, an alarm will vibrate. I didn't feel any vibration. So I thought it was tinnitus, you know, but I don't. I have a hard time sleeping, but I don't hear any noise.
Yeah. Yeah, I mean, with a single isolated event like that, it's tough to say what it was. You know, like, was it an alarm that then just stopped by the time you got up and walked around, or was it in your ears? So, you know, if it happens again, then I'd say, hey, it's probably tinnitus. So let me know if it happens again. But then the other thing is, if you have trouble sleeping, using sound therapy, even if you don't have tinnitus, is great. Just something to, you know, help turn off your brain a little bit. I don't have tinnitus. I use sound therapy.
I don't hear anything, but I have a hard time hearing. You know, I hear everything around me, but to differentiate what people are saying, I have a hard time with that.
Yeah. And if you haven't had a recent hearing test, that would be my next suggestion. So,
you know, I have a cochlear implant.
Oh, okay.
And I have a hearing aid in the other ear.
Okay. Yeah. So, so what Janice had, what we were talking about earlier is you could always get one of those, there are these pads that vibrate, and it's sound, but it's a lot of low frequencies so that you can still hear it through, well, so of course, if you have a cochlear implant, it's something that, you know, for most patients will when they're placing that electrode array, if there's any residual hearing, then that electrode array will knock it out essentially. There are some surgeons who are really good at low frequency preservation. Dr. Cass at Anschutz, he's a great surgeon. I often see my cochlear implant patients. I'm sorry, I did my residency at Anschutz, so that's where I went to school in Chicago, but did my residency at UC Health. But I would see a lot of cochlear preservation post-op with his patients. But still, sound travels most efficiently through thick, dense surfaces like bone instead of air. So you can get, if you're having trouble sleeping with or without tinnitus, you could still try sound therapy that you use through physical vibration. So, good question.
We have 3 more minutes. Any more questions? Oh, I'm sorry, Ken, you had your fill, but okay, go ahead.
Okay. Go ahead.
Yeah, go ahead.
Oh, okay. There's 2 types of hearing aids, if you will. One is the one that goes in the ear or the cochlear implant. There's also bone induction. Can you work with bone induction when people have that type of hearing aid?
Yeah, absolutely. So you just do it differently, right? So we have, when you have hearing loss that can be treated by amplification, you either have a traditional hearing aid, right? Or the bone anchored hearing aid, also called a BAHA, B-A-H-A. That is for a type of hearing loss. It's a permanent conductive hearing loss. So if we go back, let me go back and share my screen again.
Well, I have to make you co-host again when I was kicked out.
Oh, okay, that's okay. It's just the picture of the, wait, I think I am still co-host.
Oh, well, go ahead.
Yeah, can y'all see this? Okay, so when we look in the ear canal, so again, we have the middle ear, so the eardrum, those 3 little bones. What a permanent conductive hearing loss is, or let's say this, what a conductive hearing loss is something that's occurring in the middle ear. It's like when kiddos have ear infections, or sometimes these bones, the ossicles will stiffen and harden. Sometimes with head injuries, the ossicles can break. So we lose this connection. Growths in the middle ears, right? So it's I'd say, like a less rare type of hearing loss, but it certainly does happen. But yeah, a bone anchored hearing aid is a hearing solution for when you have a purely permanent conductive hearing loss. And your thresholds of the inner ear response to sound, so the cochlea, the nerve, have to be above a certain level to use this type of device. But yeah, I mean, basically what you could do is you could still do ear level sound therapy. It would just, that would be a good time to use something like neuromonics, assuming you can get the volume loud enough. So yeah, it's no matter what, let's say this, especially just for me, like I want to help everybody. So I like to get creative in my solutions, no matter what the underlying cause of hearing loss is. So.
Okay.
Well, thank you so much. This has been so informative.
Okay.
If you missed,
sorry about the internet, the Wi-Fi. I'm at my parents' house and there's like really spotty connection, and so yeah.
I got completely kicked out of the meeting. I thought, well, what if I can't get back in? Well, you would be the host because you're co-host.
Right. Yeah, I know. I was like running around and like trying to get it to where it didn't disconnect me. So I apologize.
So anyway, we are recording this. There was a lot of information. If you want to review it, you can watch the video as soon as I figure out how to post it. Okay. So thank you, everybody.
Yeah, thank you all so much. I appreciate your input.
Thank you, sir.
Yeah, you're welcome. I know, so many familiar faces today. It's so fun.
It's a small community.
I know, I love it.
Thank you,
So,
Lindsay.
Thank you.
Yes, Lindsay, thank you so much.
yeah, Lindsay, thank you.
Thank you.
Thank you.
Merry Christmas.
Merry Christmas.